Good afternoon, everyone, and thank you for coming to our Endo-ERN webinar, Patient Journeys, a tool to help patients with rare endocrine disease. This webinar is with the authors of a paper recently published in Endocrine Connections with the same name. You can find the paper in the handouts in your control panel. My name's Amy Casey, and I'm the Communication Manager for Endo-ERN, and it's my pleasure to introduce the panel today. Professor Susan Webb is based at the Sant Pau Research Center for Pituitary Diseases in Barcelona, and she will also chair our event today. From Eurordis, we welcome Matt Bolz-Johnson. He's the ERN and Healthcare Advisor. Jette Christensen is at Endo-ERN EPAG and also chair of the Danish Addison Patient Association. I'd like to also welcome Professor Anna Nordenström, who is Senior Consultant Pediatric Endocrinologist at the Astrid Lindgren Children's Hospital in Stockholm, and Diana Vitali, another Endo-ERN EPAG and chair of the SOD Italia, which is the Italian Patients Organization for Septo-Optic Dysplasia and other neuroendocrine conditions. Before we jump into the presentations, just a small bit of housekeeping. If you have questions during the presentation, please type them into the chat box and the panel will answer the questions at the end. Also, this webinar is being recorded for review purposes and will be available afterwards on our Endo-ERN website and also on our new Endo-ERN YouTube channel. For now, I wish you a very informative webinar, and I hand over to Susan Webb. The floor is yours, and I will give you control now.
Give me.
Now,
can you hear? Can you hear me?
I can hear you, and you're ready to go.
Thank you very much. Well, thank you very much, Amy and Endo-ERN, for organizing this webinar. Let me see. So I cannot pass the slides.
Okay, just give me a moment. Would you like to try again?
Yes.
Brilliant.
Fantastic. So this is the agenda. I will give you a background on patient journeys. Then Matt Bolz-Johnson, in his name and in that of Lenja Wiehe of Eurordis, will describe patient journeys, since this is something that Eurordis set up. I will then discuss the findings in acromegaly. Jette Christensen will then describe the patient journey results in Addison's disease, followed by Anna Nordenström, who will do the same for congenital adrenal hyperplasia. And in the end, Diana Vitali will discuss patient journeys in septo-optic dysplasia. Finally, we will have some conclusions and questions and answers, which we hope you will participate in, and you can put your questions into the chat box. So, more and more nowadays, patient experiences are important to improve healthcare systems and to improve quality. And abbreviations like PROMs and PREMs are being used more and more. PROMs refers to patient-reported outcome measures, and PREMs, patient-reported experience measures. And they are considered important in healthcare evaluation, and especially PREMs, if they have good results, this is associated with better quality of healthcare, as well as better financial outcome of the health institutions, and even is a predictor of survival. Patients appreciate having a good communication and trust with their healthcare providers, and having sufficient understanding of outcome of their specific disease. And this is where patient journeys can come in, because these are tools that collect information on experiences and are a simple way to identify needs and can complete the view of the clinician who's handling that patient with a specific disease. Furthermore, it allows to identify discussion points that may be of interest for the patient, but not only on medical issues, but also on emotional, psychological, social issues, or describe the natural history of the disease. Because all these issues determine the everyday needs of a patient and may identify unmet needs and problems in that specific situation. Excuse me. For the patient who has some health problem, obviously they want to do as best as possible in their everyday life, leading a normal or as normal as possible everyday life. So after a disease or an operation, elements like pain or feeling very tired or having difficulties in concentration, these are all issues that affect one's everyday life. And good quality of healthcare obviously include things like safety, clinical effectiveness, but for the patients, other elements like compassion, dignity, respect, contemplating unmet needs and gaps, social and working capacity, empathy from the healthcare professional, and providing information as a patient journey document can help to reduce suffering and can be mutually beneficial, because many times the patient is either unaware or sometimes afraid of even asking because they're not sure what sort of answers they're going to get. So having a document that describes the disease and what to expect can be of great help. So PREMs, PROMs and PJs, or patient experience measures, outcome measures and patient journeys, can help to overcome things like being anxious because of a long diagnostic delay. And of course, before you get a diagnosis, it's difficult. But once you get a diagnosis, initially that is a relief and satisfaction. But of course, this is followed by new questions, and additional support and information at that point can be very helpful. Some diseases can even be identified neonatally if one knows that that family has a high probability or genetic probability of having some disease. And in this case, the diagnosis can be made before birth, and even therapeutic measures can be taken to reduce the consequences of the diagnostic delay. As I said, these tools can help relieve anxiety and suffering, clarify confusion and uncertainty of patients and families. And often patients describe stress because there's a long waiting list for a consultation or surgery, or they have received conflicting information from different health sources or from the internet. So availability of reliable information, especially for these new patients, is really of importance. Certainly, good patient-physician or healthcare communications is important, but one cannot guarantee that after having a diagnosis, everything will go back to normal and there will be no health consequences at all. So encouraging the patient to cope with the new situation is essential, despite the presence of the disease and its consequences, and remind the patient that some degree of improvement is nearly always possible. Why aren't you moving? Oops. I don't know why the slide seems to have jammed. I cannot continue. May, can you help?
Seemingly no. Just a moment, please.
Okay.
There. Sorry,
Right.
did I? Okay.
Whoops. There we are. Thank you.
Thank you. Sorry.
This is the publication that appeared last month in Endocrine Connections. It is open access, so anybody who is interested in it can get a copy from the internet. This is the information that we collected. You can see on the left column the different stages of the journey: pre-diagnosis, at first symptoms, at the moment of diagnosis, first treatment, surgery, not always necessary, but when necessary, and follow-up care. The second column refers to the timeline, the delay, and then we have the clinical presentation or symptoms at the different stages of the disease, the patient and the family needs at the different stages of the disease, and finally, the ideal outcome or support, or how to address the needs at the different stages of the disease, at diagnosis, before diagnosis, after treatment, etc., etc. And these are the diseases and the countries where we got the results from. We adopted the previous template from what was given to us by Eurordis, who were the initial developers of these patient journey documents, which we adapted to the endocrine diseases we were interested in. And among the authors, we translated this information to the different languages you can see here, and we collected information from patients with acromegaly, with Addison's disease, and with congenital adrenal hyperplasia in the countries you can see on the slide. And with this, I will pass on to Matt Bolz-Johnson, who will now describe how they developed these patient journey instruments.
Thank you, Susan, and thank you very much for inviting me to speak today. So I just want to check I've got control of the slides. Yes, I have. So just to set us off, I just wanted to remind everyone that the ERNs, the European Reference Networks, were founded on the principle of being patient-centered networks. In rare diseases, it's important that patient experts and clinical experts come together, because knowledge and evidence for many rare diseases, due to the limitations of small population sizes, we need to leverage as much knowledge and experience out there. And that was recognised by the EURODIS, the Commission Expert Group for Rare Diseases. So the networks were founded on this principle, and therefore patient involvement in the networks was clearly set out in the legislation. But what patients bring are their experts by lived experience, and the view of a condition is more of a holistic one, lived through the lifetime of an individual and their families, as opposed to a more restricted view from the clinic. So we needed to see about an approach to enable the patient representatives to capture that lived experience and share that within the networks. With 24 networks and 300 patient representatives involved, we looked at different models for how to and methodologies for developing patient journeys. So the patient representatives involved in the ERNs are are really leaders. They're there to be a bridge between the discussions in the network and their communities, to be able to reach out to those communities, engage with them at a national level or a European level, to identify the needs which are common to people with the same condition, and also to disseminate information and knowledge from the networks. But once gathering that experience and those needs from the community, they can then step into the networks and represent those needs. Instead of speaking from the I, they speak more from an informed position about understanding the whole needs for a community. Many rare diseases, depending on the phenotype and where the disease affects, actually can have wide-ranging symptoms. So it's important to have that bridge into the community. So involved in the networks, the patient representatives are there to shape the priorities of the networks, the strategic direction and the work plans, to be able to say these are the needs and opinions from our community, and so enable the networks to be truly patient-centered and align their approach based on the needs, ensuring that the discussions are patient-centered. So I worked with one of the networks, EURN Gentoris, and we developed an approach called Patient Journeys, which are personal testimonies that reflect the natural history of a disease and the needs across the life journey. These documents aren't documents once they're written that they sit on a shelf. They're very much a live reference point. They're there to go back to. You know, the networks are about to have their 5th year evaluation. How far have they gone to achieving and tackling the needs of people? Well, those needs don't change unless the networks implement measures to improve things. So in a way, they become a reference point and a baseline to see also whether the networks have evolved care for people with these conditions. They can be used as a tool to engage with the rare disease community at large, to structure the dialogue in a national alliance or European federation, and to facilitate through workshops. And with lots of the networks have developed information for patients and families. And so in a way you could have these patient journeys as information keys. You click on it, diagnosis, and you get more information for parents and families. So they're very much a live document and interactive. So the way that we mapped this, and Susan highlighted this, was we wanted to identify for each stage of the journey what the clinical presentations are and the symptoms for that stage, identify the families and patients' needs, and also to identify what does good look like, what would have been really helpful at that point. The stages of the journey are there for the community to set out themselves. The journeys can have different stages depending on the disease area. Some could be at birth, others can be later in life. So it's about designing the stages of the journey, not having a preset list, but saying, well, what are the important stages for this condition? Once the table which Susan highlighted provides a way to just capture that information, and you can capture the information through surveys or workshops. And then we try and summarize it in a way, and this is an example of one for bilateral hearing loss. The top line here are the stages which were identified. They were slightly different to the ones which Susan had highlighted, because for this condition, these were important. What's in the green arrows are the clinical presentations. The needs and what's ideal are below. And in many ways, this summarizing it in this way enables us to engage with the clinicians for a disease-specific area and present back our needs. We come with our lived experience, but when is the opportunity in the network discussions to share that? many times I leave a meeting and don't feel I've contributed. So what we've done with these patient journeys is put them on the agenda of the ERN meetings of the working groups, the disease-specific networks, and get the patients to present them, the patient leaders to present them to the clinicians, to promote a discussion on what's important. The discussion is the important bit, and then saying, well, how does the network change and develop things to tackle these needs? Also, the clinicians can look at the clinical presentations and validate it from a clinical perspective. But in a way, they can't really validate the needs because that's the voice from the patient community. These documents can be used to inform guideline development and also care pathways or clinical pathways. You need to have at least that baseline understanding of needs and natural history of a patient journey before you map the clinical pathway. And in a way, what we've done in some areas is map the patient journey and taken a pre-existing clinical pathway and put them together. And we've identified gaps in the clinical pathway where patient needs weren't being met, and therefore we could go and update the clinical pathway. In guideline development, patient representatives are involved in all stages. So in preparation, identifying the topic areas and prioritizing what a guideline should look at should start off in that discussion about patient needs. So the patient journeys are important there. They're also important in help formulating the PQ questions, identifying outcomes and needs which are important. And here is a list of the patient journeys we've developed so far. There's 53 of them. We've done them for quite a few of the ERNs, and they're one tool which we now have, which can support patient representatives to present their lived experience and their expertise gained from a lifetime in these discussions with the clinicians. Thank you.
Thank you very much, Matt. Let me see. Can I move on to the next slide? Yes. So now I will briefly describe the results of the patient journeys in 6 patients with acromegaly. Actually, in one case, it was a patient association. So they described globally in their own summary from 4 different countries. Pre-diagnosis, there was a long diagnostic delay. In one instance, it was only for 3 months, but the majority had some health problem or experience that something was not right for many years, up to 15 years before the correct diagnosis. Clinical presentation of symptoms was rather, let's say, typical of what one would expect of acromegaly. The problem was that it was not recognized that it was due to the disease until some years later. Headache, carpal tunnel syndrome, that is having sort of tingling and pain in their hands, excessive sweating, menstrual irregularity, feeling tired with less strength, and then growth of hands, feet, and tongue, which determined lisping and sometimes finding it difficult to be understood because of the increase in size of the tongue when talking. Joint pains, facial changes, which had developed very slowly, but are often, let's say, suddenly identified by someone who hasn't seen that person for a long time. And this is often the case. Patients have more body hair than they had before. They have started snoring or even have sleep apnea, have gained weight. Their skin is thicker. And one thing that can be identified if one knows about it, going to the dentist who suddenly realizes that the teeth are more separated than they were before because the jaw has grown, and this may determine toothache. High blood pressure, well, it can be due to many things. And feeling something is wrong, but not knowing what. Psychological issues like insomnia, lack of concentration, less memory, unreasonable nervousness, depression, fits of rage or irritability. And then, sorry, there are less frequently described problems which on retrospect could have hastened the diagnosis, like a young woman who several years before had had a baby, and it was mentioned at the time that she had an unexplained very large placenta, which was obviously part of her acromegaly. In another case, the patient had a change in voice, and the ENT surgeon saw that the mucosa of the larynx had grown, and it had created a hernia which affected the vocal cords, and this explained the voice change. This was the second time he'd seen it, and he was then the person who identified the patient as having probably acromegaly, which we then were able to confirm. And then patients describe a change in their smile. What about the patient and family needs? Well, there were two different scenarios. Some said no one really suspected there was anything wrong. The problems like the increase in weight, the change in facial features, etc., or the other problems I've described were thought to be related to stress, to aging, to weight gain or lifestyle changes. While the most frequent situation was that the patient had experienced problems for years and had repeated consultations with different specialists or primary healthcare with no recognition of the symptoms as part of the disease. And this obviously, in the long run, determines stress and an impairment in their quality of life. They wanted to know and understand what was going on so that they could relax and feel at peace with the situation. Some of them described fear of the reaction of relatives when disclosing the diagnosis because of misunderstandings. And they really appreciated the possibility of getting high quality information, as well as good care and empathy by specialized multidisciplinary reference centers who could then offer a global care. In the case of acromegaly, which usually has to go to surgery with an experienced neurosurgeon, patients do obviously want to go to an experienced group, which sometimes in some health systems is difficult to get under public health care, and some patients described that they had to go to a private center, and this obviously is not good for patient equity. They also mentioned that they appreciated honesty of healthcare providers if not familiar with the disease, so that they could be referred to a specialized center. They were scared on the term radiotherapy, which is usually associated to cancer. And they suggested or asked for an earlier recognition by specialists who could see these patients, like sleep centers, because the patient had been snoring and were referred to a sleep center, neurologists with headaches, ENT specialists, as I just mentioned, dentists, gynecologists because of irregular menses or infertility, orthopedic surgeons because of the changes in their joints or their bones. And they even mentioned jewelers, which if your hands have grown and your ring doesn't fit anymore, you have to go to a jeweler to make it larger. Well, if jewelers were more aware of this, it might help diagnose some of these patients before. The same as even shoe retailers, because it is extremely rare that one should increase their shoe size once you're an adult in more than one number. And then finally, understanding that acromegaly is a chronic life-changing disease and learn to live with this disease in a positive way. Ideal outcome support, well, listening to the patient at all health levels. And they often complained that they were not taken seriously, despite knowing that something was wrong. Increase awareness of the disease at all health levels to reduce the diagnostic delay and prevent irreversible changes related to the long exposure to excessive growth hormone and IGF-1. Empathy by primary care physicians to prevent delays in referring patients or in ordering diagnostic tests, having access to multidisciplinary expert teams for diagnosis and chronic follow-up, shorten the waiting list for surgery because it's very stressful waiting for a surgical procedure which you know can normalize your hormones, and sometimes this can take several months. The importance of patient associations, to be able to share experiences, because this can be very, very helpful because they get better information and this leads them to acceptation of the situation and being more relaxed. In some cases, however, a psychiatric or psychological reference is necessary, and then the interest of using questionnaires to evaluate quality of life or different aspects of the disease, because it helps the patient realize that some of the things they've been experiencing are really related to the underlying disease, and it's not something that they've made up, or they're not crazy and they're not hypochondriacs, but they really are experiencing things related to the disease. So with this, I will pass on now to Jette Christensen, who will describe patient journeys in patients with Addison's disease.
Hello.
Hello.
My name is Jette Christensen. I'm the president of the Danish Addison Patient Association. When I got my Addison's disease 25 years ago, I could not read anything about the disease anywhere. I couldn't get any information, and I didn't know at all what that was. I could only rely on my doctor, and he just told me, take 30 milligrams hydrocortisone per day, 20 in the morning and 10 at night, and then you'll be good again. Well, I didn't. Other Addison patients were in the same situation, so we formed an association in order to get to know more about the disease and spread it to others. Around 2010, we established a European adrenal network of patient associations in order to share experience and information. And also endocrinologists were involved, as both parties found out that patient involvement and dialogue between doctor and patient were crucial factors in rare diseases. When Endo-ERN was established, I joined as a patient representative, as an EPAC, to help extend this dialogue between patient and doctors. I chose the work package Quality Care and Patient View, where we have had a very fine and fruitful doctor-patient cooperation, respecting each other's qualities and special knowledge. And the results and data from the Addison patients who answered the template of Addison's disease, there were 6 patients from 4 different countries. Our latest joint project was the Patient Journey Project, with which we wanted to give patients and their caretakers an example of how they could use a simple patient journey template to illustrate the journey of an adrenal patient from diagnosis to treatment and follow-up. We wanted it to be as simple as possible to ensure that all patients would understand it and therefore would be encouraged to use it, fill it in and send it back to us. We agreed that we did not want it to be a scientific project, it couldn't be, but a purely patient-oriented survey. Through our patient association network, we chose the patients from different European countries, and we focused on the diseases acromegaly, Addison's disease, and CAH, as Susan already told. We translated the template into the national languages so that the patients could fill them in and return them in their native language. And we succeeded to get quite a few returned. And here are the results. Regarding pre-diagnosis, it was very symptomatic. But after diagnosis and start of treatment, there was a great improvement. The timeline was between 6 months up to 10 years before people got their diagnosis. The symptoms they reported were nausea, vomiting, fainting, extreme tiredness, loss of weight, skin pigmentation, anxiety, hypotension, salty food craving, and shortness of breath. And everybody found that it was difficult to find the correct daily dose. And as to the patient or family needs, there was no understanding by the family. So the family should be informed of the patient's problems and concerns. And everybody, well, many said it was so good to get a diagnosis and not feel like a hypochondriac, because they have been to the doctor very often and couldn't find out what it was. And there should be education also to the family on physical and psychological situations that require extra stress dose increase of glucocorticoids. The ideal outcome, they all told that finding staff who listen to the patient is very important, as well as education and access to knowledgeable specialist information. And it was so good to get clear information how it is to live with a chronic disease like Addison's and what to expect. So many were told, take your pills and you will be okay. But they found out, no, I didn't get well, at least not at first. And also to have awareness of other endocrine deficiencies which may accompany Addison's disease. You often not only get one autoimmune disease, but you get others. And it was very important to have a stable follow-up team, as in not changing doctors, but have the same doctor who follows you and who knows you. And awareness of the need to adapt the daily treatment to personal timetable and activities. That is not a standard treatment, but more like an individual treatment. And the importance of training on crisis management is enormous in Addison's disease. Access to emergency injection kit is very important, as well as access to constant medical support and access to hydrocortisone at all levels. Thank you very much. And I will now pass on to Anna. Please, Anna.
Thank you, Jette. Let's see if I can move the slides now. Not yet. No.
Let me try it again, Anna. Will you try again, please? Thank you.
Yes, so I will just tell you a little bit about what we found from the patients with congenital adrenal hyperplasia in this sample that we achieved in the patient journey. And of course, there are big differences if you're diagnosed via the neonatal screening program. That means that you have your diagnosis from birth, and most of the stressful first occasions or the first information is for the family, the parents, or if you get the clinical symptoms later in life. And the time to definite diagnosis creates a lot of anxiety, as for the other diagnosis explained today. But here it's also the issues of sex assignment in the initial few weeks for the girls with CAH, since they're exposed to high levels of androgens. And also there's additional anxieties related to the genital virilization and the surgery, and if it should be done early or later when the girl can decide herself. For adults, there's often a very long diagnostic delay, and it is accompanied with more and more virilization and androgenic symptoms, such as hirsutism, for example, or PCOS-like symptoms. And parents describe difficulties taking in the information, maybe more so if the diagnosis via the neonatal screening, when the parents have not noticed any symptoms at all from the child. So it's really difficult to take in that the child has a chronic disease, and you see no differences in the child. Otherwise, the experience related to cortisol deficiency is very similar to the Addison's disease. And the families and patients, they requested more patient and family support groups, and also they suggest to use national registries so that it would be easier to find other patients with the same diagnosis. It's also very important with clear information for sick day rules and acute situations, as Jette mentioned, both for parents, patients, but also for other healthcare personnel, especially in the emergency situation, in the emergency room. So they had a very valuable suggestion, I think, that there should always be they should always be cared for by specialists in a multidisciplinary team. But there should also be on-call phone number in case of emergency, both for the patients to use, but also for less experienced physicians to be informed about what to do when they have a patient with CAH. So I think this is a very good information that it's very valuable for us to improve the care for the patients. And now I think I should hand over to Diana.
Thank you. Amy, tell me when I should try to
See if you can control now. Go ahead.
Yes, if I press the audio. Okay, if I press the arrow, I try this or this. No, so you can do that for me, Amy, so we don't lose more time.
Grand.
And this question was posed to me by Susan. So we are doing this little presentation on my side with this trying to answer to these very important questions. And yes, as you said, as everyone are saying, the patient journey are a tool. It may be the simplest way to collect all the experience of patients and the knowledge of professionals. But for me, above all, PJs are a concentrate of awareness and sensitization, because we really, as patients, we really need to have this path to through the first symptom to the cure and to the complete awareness of our conditions. And that is the most important things for a patient, I think. And as experts, both patients and doctors, maybe we forget that in rare disease, it is still very difficult to find information, of course, more in very, very rare diseases. And the most important things is about experienced doctors, but it's very difficult to find other patients and allies and the sharing of the experience. And so every step toward greater knowledge and awareness is more difficult. So Amy, can you change the slide? Very often, when the true cause of a symptom is understood, it happens that it is already too late, and this is more important and more evident in endocrinological rare diseases, where the risk of a diagnostic delay is very high. When I mean risk, is that if you don't treat the symptoms, if you don't treat the disease, you have problems, more and more problems, and they are very big problems. And in this perspective, also the importance of the delivery of the diagnosis is underestimated, in my opinion, because it should be considered as a process and not as a single act. And that's because the patient needs time to become aware of his condition, because at the first it's a kind of shock, so he doesn't understand very much of it. Maybe the doctors are telling him a lot of things, but they soon forget or they don't hear it. So I think that is a very, very important moment, the delivery of the diagnosis, and we should improve this process with more time and space for it. And so usually the journey, the patient's journey, is going through research, discoveries, special encounters, I mean very special person, and very often there are many regrets, guilt, flashbacks, and all these psychological aspects, both for the patient that for parents of the patients, maybe more for the parents of the patients. And so there's this need to rebuild oneself within new sets of experiences. I may please change the... So really the patient journey that they have this very valuable graphics, so can really make all of this process very easy, and they are very immediate and simple, and so they allow a global vision of the situation and an immediate identification with it. And so they can facilitate the understanding of the symptoms, the perception of the pathway, and the knowledge of the therapy. And I think very often in endocrinological disease, the symptoms are very strange. And so that is, when you read about it, you really immediately discover that you have that, because otherwise it's very difficult to describe them. So the patient journey really facilitates the process of awareness and knowledge, and through the sharing of experience facilitates the acceptance of the disease. That is the first step towards treatment, because when you read the patient journey, you understand that other people have had it, so you don't need really to meet them or to have the association or to have many of them near you. And it's immediately that there is a sharing of it. So I may be the last one. And in fact, the real odyssey is the ignorance of what you are going through and what is happening. When my daughter was born, it was in 1988, and it was the way of life was very difficult then, so it was very difficult to find information, and we couldn't have a proper treatment. So I remember very well when with the internet and the diagnosis, I could read about the characteristic of people with hair condition. Once I received the diagnosis, and once I started to navigate on the web, and I cried with joy as if I had woken up from a nightmare. And I think that all this feeling of nightmare is that prevent you to cure yourself very well or to treat yourself very well, because if you don't accept this problem completely, you also have a negation. You say no to it. I don't know if I would say in English. Anyway, and next slide, please. So for me, in my health, today's serenity comes from a deep awareness and sharing of the experience. And I really think that the patient journey can facilitate all of this. That is, provide general information about different aspects of the disease, the cause, the patient's needs, and the social rehabilitation aspects. Fosters trust in doctors who prove to be expert and willing to listen to all the patient's needs. That is very, very difficult to understand that during a visit. And they are a demonstration of a shared experience and a sustainable experience, so that many people does it and many people can survive it and also have a good life afterwards. So in my opinion, I like this patient journey very much. And my next question can be, how would the patient journey help? I would help the association, because I tried to promote a patient journey for SOD or for a more wide patients group like congenital hypopituitaries, but it was very difficult to do, because still the network is not very compact or strong, and also the phenotype of the condition are very different, and still the patients are not so willing to participate, are not so aware. So I hope in the next months, in the next year, we will succeed in developing a patient journey for this condition too. So thank you, everyone.
Thank you very much, Diana. I think that Jette and Diana's testimony have certainly shown me, and I think I also will talk for Anna and for Matt, have shown us all how important it is to get the patient point of view, because after all, you are the experts on that disease and what it is living with that disease. I mean, we professionals know about the theory, but the practice of living with this disease is something that you, the patients, are the real experts on. So can I move on to the next slide? Or if there we are. So I think that what we have learned is that patient journeys may identify gaps for improvement in diagnosis, treatment, patient education, and access to knowledgeable multidisciplinary teams. And it's really curious, but not surprising, I imagine, that despite rare endocrine diseases being so varied and so different, from mild to severe, the feelings of not having been taken seriously, both by the healthcare professionals and the patient's close circles or family, is very common. And we have heard it both from Jette and from Diana. When possible, as Anna explained, screening shortens the time to diagnosis and prevents some of the initial severe symptoms and possible sequelae in certain diseases, not in all, obviously. Convey that these endocrine diseases, these rare endocrine diseases, are usually chronic procedures that require long-term follow-up, and being aware of this facilitates a way to adapt to living with this chronic condition. Patient tools create a discussion and partnership between patients on the one side and clinicians on the other. And this, as Matt said at the beginning, is useful for the Endo-ERN to propose new activities or strategies. We cannot stress enough the importance of empathy, of listening to the individual patient needs, and create a positive patient-centered environment to improve clinical practice and reduce health costs too. So it's not only to devote to the affected patients, but also help the whole society if we are more efficient in spending our health costs. And considering the impact of rare endocrine diseases on everyday life, contemplating social, financial, educational, family, and leisure issues with realistic expectancies, and correlate this with a reduction in health costs related to both physical complaints and psychological problems like stress, depression, and anxiety is important. And we hope that having produced this webinar on patient journeys will help to all these things that we have been discussing. So I think, yeah, the final comments would be that patient journeys are an instrument which can be extremely important. We've heard how the patients or the EPAGs appreciate it, and it was a great idea for Eurordis to develop them initially. I can't stress enough the importance of listening to the EPAGs and patient associations and individual patients. And finally, that patients' experiences and opinions are a complement for optimal outcome of our health procedures. And with that, I think we come, if this moves, to the end. So we now have some minutes for questions and answers. And I don't know, Aimee, how you want to do this. I cannot see if there are any questions or answers. Perhaps you can help us.
Yes, if the attendees have questions, they can put it in the chat, or if they would like to raise their hand, I believe I can unmute. May I ask a question?
Please.
I'm just curious about the patient journeys that Matt was talking about and how there's a repository of them. How can people on the webinar actually access those?
I think most people know Lenja and Rita in the Eurordis team. They can connect with them and see which ones are available. The best thing to do then is to signpost to the patient representatives who've developed them to share them with them. Many of the networks are using them internally to identify common needs and promote the discussions within the network about what's important, where to channel them. So the ones which have been developed in the ERNs are quite visible, but we haven't made them visible between ERNs, and maybe we need to look at that.
Okay.
Matt, do you think it's possible if patients, because not everybody is so knowledgeable about the Endo-ERNs or the ERNs in general, So if they Google, say, Eurordis patient journeys, they will probably come up with some information which can then lead them to where they want to go.
Absolutely. If you Google Eurordis in European reference networks, you'll see the team which are based in Barcelona, and they will be more than happy to share information with you. And if you're interested in developing a patient journey of your own, we can support you in that.
Good. Well, I think that's where everybody goes nowadays when they want to look for something. They go to Mr. Google or Dr. Google. So it's good to know that that's a good way to start and go on from there.
I don't see any attendees putting their hand up or asking questions. Just to remind everyone that the paper that was published is actually available in your handouts. Is there anything else, Susan, that you would like to address given that we don't have any questions?
Well, I think that I have learned a lot from this suggestion, as I said, initially put up. I think it's nearly 2 years ago by Jette and Diana. And Anna and I were not so clear what we were going to do with this. But once we got started and found the information, contacted Eurordis, and after several problems really got going, I think that I have certainly learned a lot. And I hope that it will be useful for future patients. So I would say to those who are listening or who may see this webinar on YouTube, do try to find information on your disease. Do ask your healthcare providers, but if not, you can always try to contact us. We just said before, Eurordis or the Endo-ERN or the ERNs as total, because there are 24 different ERNs on rare diseases in Europe, and probably you will be able to find some information there. And hopefully this will be an exercise which will help us create some further documents or information which may be of help, hopefully, for future patients.
Very good. Well, I'd like to thank the panel very much for taking the time to present this information. I think that those that have attended and that will see it, as you said, will find it very useful. And I think it's good to reflect on, as an Endo-ERN and an ERN member, that it was the patients that were the impetus to start this. And it's great to see that they continue to be at the center of the conversation. So I'd like to thank you all for your presentations today, and I would like to thank the attendees for coming. And we will follow up with you with the recording if you'd like to share it with your colleagues, and also a survey to find out what you would like to hear about next. So with that, I will close and bid you all a good night.
Good night.
Thank you.
Thank you.
Thank
Good
you.
night.
Bye-bye.
Bye-bye.
Bye-bye. Thank you.